partial knee replacement. So, everyone,
Thank you very much, everyone, and good morning, Karachi. Thank you for having me. It's been a great few days here. It's my first time in Pakistan, and I've thoroughly enjoyed it. I wanted to say a quick thank you to the chairman for having me here, Dr. Omar Bhatt, Dr. Imran Shah, Dr. Yasir Khan, Dr. Mujahid Jamil, and Zishan Shah as well. Zishan Khan, sorry, and the rest of the faculty. So thank you again. It's been great having you. I work in Oxford, and I'm going to try and convince you to why partial knee replacements are important. And but perhaps the most important disclosure I don't have here is the fact that I trained in Oxford. I did my PhD on partial knee replacements and how to teach surgeons how to do them. And I did my fellowship there. So you might say I'm biased or I'm brainwashed, but what I'm going to do in the next 5 to 10 minutes is just present you the evidence and try and show you that actually this is based on good scientific data and try and convince you to utilize more of it. So when you're presented with an individual with medial compartment arthritis, either of these two operations are useful, and both have their advantages and their disadvantages. And the majority of people would do the operation on the right, but more and more individuals are realizing with the evidence and the benefits that partial knee replacement is a very good option. So what would drive change? This was very difficult around 10, 15 years ago in the UK. We were trying to do this. So you need evidence. You need guidelines. You need patient choice. You need patients to decide what they want based on the data that's given to them by the surgeons. And you need to maintain a safe arthroplasty practice. You don't want revisions. And knee replacements traditionally got a bad press because of the higher revision rates. And what you want to do is to train, as we've heard today, the up-and-coming group of surgeons who can change our practice. So the advantages of partial knee replacements over total knee replacements are clear, and I'm going to present to you all of these factors. We know that there's faster patient recovery, shorter length of stay, lower complication rates, very importantly, things like heart attack, stroke, pulmonary embolus. There's half the deep infection rate, extremely important, lower mortality, and actually better functional outcome. So is there any disadvantages? Well, some would say yes, there's the higher revision rate. But if I put to you that if the revision rate is the same, then it's a no-brainer. You'd use the operation on the left, as we saw. So let's start with some of those. Well, rapid recovery lends itself well to partial knee replacement. This lady had an operation an hour and a half before this video was taken, and you can see her walking up and down the corridor, pain-free and comfortable. So we know it allows you to recover faster due to less trauma of the operation. And because of this, we know patients have better functional outcome. These are data from the Nuffield Orthopedic Center, and we compared our total knees versus our U-knees over a 5-year period. And you can see here that the bar on the left-hand side is the Oxford knee score, 48 being the highest you can achieve and 0 the lowest. And you can see there are more individuals with U-knees who have an excellent score, and there are less individuals with who have a poor score with a U-knee. So if you want to be the best you can be in terms of your function, you want to have a U-knee, okay? And if you want to decrease the likelihood of having a poor outcome in terms of your function, then you should have a U-knee. So they've got less poor results, more good results, or excellent results rather. So what about the complications? These are really important. Individuals, especially in Pakistan, present late because they're worried for the fact that there may be complications associated. They heard their neighbor had a heart attack or died having a knee replacement, and it's been the same all over the world. So what we can show you is actually based on good data. This is one of our research fellows, Alex Liddell, who published this in the Lancet, one of the best known medical journals. Not many orthopedic papers go in there. It's for the real deal cardiology, oncology papers, not for orthopedics. But we managed to get this into the Lancet, and we showed in a big data study matching the National Joint Registry with the hospital episodes records of the patients, that unis have 1.5 times lower length of stay, lower readmission rates, less intraoperative complications, transfusion rates, and also, more importantly, lower important complications. So all these complications are half. So heart attack, stroke, infection, which is devastating, and thromboembolic disease. Okay, my children are calling. So these are very important to patients. They don't care about revision rates when you talk to them. They just think they want to be out of pain, but they do care if they have an in-hospital cardiac event. And more importantly, they don't want to die. So you can see here, unis compared to totals, half the risk of dying. I know it's not something you discuss with patients, but I do you don't do it all the time, but I bring it up and I say, there is half the chance of dying during this operation compared to a total knee replacement. And this is very convincing evidence. So what about the randomized trials that are there? So again, more evidence, again in the Lancet, the TopCat study, I don't know if you've heard of it or not, was a randomized controlled trial carried out in the UK, and it wasn't just Oxford, it was all comers, all district general hospitals, all small hospitals around the UK, and the surgeons weren't handpicked. They were just surgeons who would either be happy to do partial knees or total knees. And it's probably one of the best orthopedic experiments that's been designed. I didn't design it, one of my colleagues did, and it showed again that the five-year revision rate was actually equal among non-expert UKA surgeons who just happened to be trained in unis, but they weren't designer surgeons, they weren't people working in specialist hospitals. They were your average orthopedic surgeon who was appropriately trained, and at 5 years the revision rate was similar. What about the expense? You need to know whether an operation is going to cost more. But again, we saw that in terms of cost effectiveness, which is very important in many communities, this favors the uni. So have a look at this paper if you want to go back to your hospitals and justify why you should be doing unis. What about the disadvantages? We talked about the revision rate, and yes, traditionally in the National Joint Registry and in a lot of registries, the revision rate is lower when you look at it at first glance. Great. So you can optimize your revision rate by increasing your usage. So this is an interesting graph. You can see here, it has the, where's the clicker? It has here the usage of unis. So it's the percentage of your knee replacements that are unis. So it goes from 0 to 100, and this is the revision rate. And you can see that as your percentage of unis in your practice increases, your revision rate increases. So you've got to be if you're doing less than 20%, then you're going to have a pretty high revision rate. But if you can get up to 20%, or even the best sweet spot of about 40 to 60%, then your revision rate is the lowest, okay? And so we recommend that people should be trying to get to 20 to 50%. And so it's not the numbers that you do, it's the percentage of your practice, of your arthroplasty practice, that's unis. So if you could do that, you can bring down your revision rate. And again, this was another paper we looked at the usage again of individuals compared to their revision rate. And actually, if you match the unis and total knees, their 8-year survival rate is similar, okay, with optimal usage. And no difference in hospital readmissions or reoperations and complications. So looking at the outcomes, again, my team looked at this and we published it in the BMJ, a journal that doesn't really like orthopedic papers. They're interested in more highbrow topics. And we wanted to look at this and all the relevant patient-relevant outcomes, things that are important to patients. and did a systematic review and meta-analysis of this. And we looked at hospital admission impact in terms of the length of the operation, the length of stay, risk of early complications and death, success of the operation in terms of range of movement, patient-reported outcomes, pain relief, and also the rate of recovery and the return to work, and reoperation and revision rate. And actually, in all these parameters, in all the data that was present in a number of registries, several randomized controlled trials, and several case control studies. So everything that's out there in the last 20 years, and the uni was superior in all of these, except the revision rate. And this is because of what I just explained to you in the previous slide. So if you can address that revision rate by increasing the proportion of unis you do, then all of these are in favor of unis. So it's a no-brainer, really. So based on this evidence, the NICE, the National Institute of Clinical Excellence in the UK, changed their guidelines in the last 2 years. And actually they've said that we should be offering a choice of partial or total knee to people who are with isolated medial compartment arthritis, and discussing the benefits and risks of each operation. So really, as a knee surgeon in the UK, if you're not able to offer both these operations, in the future you'll have to refer them to someone who can, and you do really have to present both these operations to patients. And traditionally people wouldn't even mention the uni to patients. So this is now changed government guidelines, and it's really hard for those of you who've worked in the UK. You know that NICE don't change their tune for anyone, and it's taken a lot of time, but actually they've seen the evidence and they've changed their mind. So you have to put it to the patients. You speak to your patients, you share your information and their preferences, and ask them. And inevitably, everyone we see in clinic, when you present it this way, they say, I want a uni. And actually, sometimes when they're not suitable for a uni, they get upset that you've offered them a total knee replacement. So maintaining a safe practice, which I mentioned to you, you have to stick to the indications. So if you just operate, and I'll speak to you about this in my next lecture on standard anteromedial osteoarthritis, 50% of your patients out there will have anteromedial arthritis. You might be thinking I'm talking rubbish, but if you go back and look at the last 20 knee replacements you've done and have a look at them, they'll be suitable for a uni. It's just bringing yourself to do that operation. And we know surgeons can't increase the volume of knees they do overnight, but they can change the proportion of knee replacements in their practice that are unis. And if you can do that by sticking to the indications, you can bring down your revision rate dramatically. And then we talk about training. This is the UK in terms of unis versus total. You can see we weren't great. Things are improving, but still, even in the UK, about 10% of our primary knee replacements are unis. And in a place like Scandinavia, where it's a smaller community and everyone knows each other and everyone's able to disseminate the data and essentially the training, they've gone up to 30%. And one of their main professors came to Oxford, worked with me and my colleagues for 6 months, and he's gone back, and that country has just dramatically changed in the last 3 years. So there's still work to be done, but as surgeons are coming through, they need to be exposed to partial knee replacements as a standard part of their practice. And if they can't get that, then they can go places and visit places like us, Oxford. Everyone's always welcome to visit, to be able to get more exposure to partial knees. Because as I said, the advantages are clear in terms of over the PKR. There's faster recovery rate, shorter length of stay, fewer complication rates, reduced 90-day mortality, half the deep infection rate, and functional outcome. And if you can get your revision rate to the same as totals, then there's a no-brainer. So all the drivers for change are for your practice to support the increase in the use of partial knee replacements. And I hope we can convince you in the next few sessions to go out there and try it. Thank you very much.